my study is a randomized study, a phase 3 study, and importantly, it's an investigator-initiated study. It's called Peace-3. It's a study from these peace consortiums, and it's in reality a NeoTC study in collaboration with a lot of cooperative groups. So it was really nice to like the collaboration with everyone. The question was if in the setting of first-line mCRPC, so for patients who progress on ADT alone without having had a prior RP, the addition of radium to enzalutamide gives a benefit for rPFS, that was our primary endpoint, but also for overall survival, versus enzalutamide alone, what is the standard of care. And that was really kind of a very nice result, that the rPFS that we had targeted with a 32% of improvement had a 31% of improvement for radiological progression-free survival and death. So that was quite interesting. In more concrete numbers, the median OS went from 16.4 to 19.4 months. And we saw also in the log rank test, again with a hazard ratio of 0.69, a benefit for overall survival. The overall survival curves are crossing in the beginning, so the log rank test is not an ideal test, so that's why we decided to go to the final overall survival analysis. Also, this is the time to next systemic treatment was prolonged in the combination arm. What we also saw is that the time to pain progression was no different, and also the time to first symptomatic skeleton event was not different. But I think one really important point is that we made the use of bone-targeted agents mandatory. And this is something I think is a very important message that we got out of this study, and also already with Radium-223 that had a similar design but used abiraterone together with radium. We saw an increased risk for fractures in the combination arm, but even for enzalutamide alone, without bone protecting agents, the risk was about 15% of fractures. So it's really important that we think about giving bone protecting agents to patients with mCRPC. I think this is another important message from this study. Yes, so for the safety, I think it's really interesting what we saw in both arms. The most frequent term that was used is hypertension, and it was about 30% in both arms. So we really, and that's probably caused by enzalutamide, and I think we have to be really careful monitoring our patients for hypertension, because the really nice thing is that now we have a long overall survival also in that situation, but that means that we have to take care of the metabolic side effects that we are inducing. And it's important, I mean, that can be done by a GP, can be done by the oncologist, but it's really important to measure hypertension, blood pressure. The patients can do it on their own at home, however you're doing it, but you have to monitor hypertension. For the addition of radium, we saw myelotoxicity as expected. And we had in total drug-related adverse events grade 3 or higher. We had, I think, 19% in the enzalutamide arm, and it went to 28% in the combination arm. So about 10% more, so we have to take care of that. There was more fatigue. I guess these are the things that came up as grade 3 and 4 toxicities. There was also more diarrhea as we expected, but you know, fortunately not in that high grades. So, you know, I think what is nice is that we have now a new potential treatment option for first-line mCRPC. Remember, these were patients progressing on ADT, so not patients that had the current standard of care ADT plus an RP. I think that's an important limitation, but still we know that globally a lot of patients still get ADT alone. I really hope that that's going to change in the next years, but this is like real life evidence that we have for the moment. So for these patients that would fit the inclusion criteria and are progressing on ADT alone, have bone metastases, I think this is a new valid option to discuss with your patients.